Hi, my name is Peter. I'm an emergency physician from Denmark, currently working in Sweden. And today I want to talk with you about the PREOXI trial and lots of much better analyzers and podcasters have done this trial because it's probably a game-changing trial for many. So I'll encourage you to go check, if you haven't already, check out First 10 EM's take on this, check out Rebel EM, check out MCRIT and the SGEM, and so on and so forth. We're doing this as a journal club for one of our education weeks at my hospital, and I just wanted to go through this so that all of our residents have somewhere to go if they are not attending, and so that we can talk about this in clinic. All right, so what we're talking about is the PREOXI trial, or the title is shown below here: non-invasive ventilation for pre-oxygenation during emergency intubation, which came out in June of 2024. And I'll frame it with a case. So you have a 70-year-old patient with a fever for 5 days, coughing, and now has a hard time breathing. The CT shows pneumonia, and the patient becomes worse on the way back from the CT to the ED. Now setting 82 despite 15 liters of oxygen as he arrives in the ED from the scan. And anesthesia wants to intubate. How do we, in the best way, pre-oxygenate this patient? That's the so this is the framing of the case today. So I've already done journal clubs before, and I will encourage you to go at least watch the introduction to these two journal clubs, especially this one, because in those I've gone through kind of the nuts and bolts of evidence-based medicine and trying like how to approach a trial. And I've done several other videos on a wider on the wider topic of evidence-based medicine, but here I just wanted to go through this trial and not go too much into the larger framework of how to do journal clubbing. But if you want to know more about that, I will encourage you to check these out, and I have links to better EBM emergency physicians than me as well. If you want if you want to hear this from other mouths than mine. Okay, my formula is inspired by several big names in this area in emergency medicine, but I'm drawing a lot of my experience and my inspiration from Anand Senti, who has the EBM 2.0 homepage, and the thinking about probabilistic thinking and taking our clinical probabilistic thinking to the way that we also do journal clubs, I think is a big game-changing thing that I learned through Anand Senti, and also through Broomdogs and through First 10 EM, Justin Morgenstern. So my formula is like this. Of course, when we have a paper, this is what it looks like. Like usually there's some kind of introduction and objective, and then you have the method section and the results section. And this is the one that we are going to concentrate on. This is the one that is important in the paper. The discussion and the conclusion, that is the author's take on what they found, which is oftentimes with a high degree of bias, and you can sometimes read into what their biases are as you have your interpretation of the result and they have their interpretation of the result, and the mismatch between your interpretation and their interpretation is usually where the bias comes through, but also your own bias maybe. That's why it's nice hearing others' opinions on the same piece, so you can kind of tease out where the biases are. And the introduction usually just sets the stage for why this study is important. So what we actually want to know, like many people jump to the results section, and that is important, but the results are only as important as like, okay, this was really, really significant, but if the methodology was bad, then I don't trust the results, even though even though it was an amazing result if it was true. But the if it was true is like the truth comes out in the method section, and that's where we want to stay in journal clubbing. Okay, so my formula is pretest probability assessment, meaning that you kind of check the background, both the bioplausibility of the theme that we're going through, and also the known evidence, both from the specific area that you're checking, that you're doing a journal club on. So, but also in adjacent areas, if there isn't any evidence in the specific area that you're doing a journal club on. So, for instance, if we're doing a journal club on tranexamic acid in head trauma, then we might also look at the evidence on tranexamic acid in other areas to like kind of see whether this actually works anywhere. And so that's if you want to go into how to do that, then you should check out the journal jams from EM cases or first hand EMs like Justin Morgenstern's posts, because he also goes into this almost every time. The bioplausibility is whether or not the mechanistic argument makes sense. Like, does it make sense that we use non-invasive ventilation for pre-oxygenation as opposed to just like normal oxygen? Does it make sense? And we'll go into that. But sometimes something that mechanically doesn't really make sense, that's just one puzzle piece, but it's an important puzzle piece that informs us that like a result that might be too good to be true probably is, if we can't explain the method behind why it's working. And there are some great therapies that we don't know why they work, and so it's just one puzzle piece. But if the other things don't line up, then this is also a puzzle piece to be aware of. Okay, then you go into the study, and I've listed a Fagin's nomogram out here because of the probabilistic way we're going to go through this. So your pretest probability lands somewhere on this spectrum. Then the study is seen as a test. So we'll go through how we do that, but the test lands somewhere, whether either it's a negative study or it's a positive study. And I know there are nuances to that, but let's just call it either positive or negative. So if you beforehand were very convinced and this is a lightly negative study, then you're probably kind of in the same ballpark. Your post-test probability after the study will not change too much. But if you were very convinced and it was a really big, really good study, then suddenly you are much more likely to be doubtful of this area. You may still practice this way, but not with the same security, right? Not with the same you're not as sure in that decision as you were before. And that's that's the part of the scary thing about science and about journal clubbing and about evidence-based medicine, because it shines a light on some of the things that we might be doing that we maybe shouldn't be doing, or maybe shouldn't be too sure about doing. Okay, so the background informs our pretest probability where we are, and this is not purely scientific. There's a lot of wiggle room for subjective kind of what do we think, and also our experience oftentimes informs our pretest probability. And Simon Carley has done a great piece on why we can disagree. If we agree on the same result, why do we disagree? And that's why do we disagree on whether we should implement it or not? And part of that discussion is, well, because we have different pretest probabilities, even though we have read the evidence and we do have the same bioplausibility, maybe there's some subjective part of our pretest probability as well that makes us go up or down. That cannot just be explained by like objective knowledge. Okay, and then as everything we do with likelihood ratios, we both measure the amount the likelihood ratio goes up or down, like the weight of the test, how good is the test, but also how much do we believe in it. And that's part of the analysis. Like, okay, this is the result. Do we believe in the result, or is it a crappy study and therefore we don't believe in it? Then we don't believe too much in the likelihood ratio, and that's the same goes for the clinical likelihood ratios that we have, right? And then afterwards, back to reality. What is our post-test probability, and what is my take-home? What am I going to do afterwards, after the journal club? And oftentimes the answer is not much different. I'm not going to change much because it takes several trials in my kind of setting to change my practice. And also we have the pressure of guidelines and the pressure of culture of how we practice, where we are, and so on. So it's not all. There's oftentimes something like we push small changes are being done, and after a while, if enough studies come, then it will be a big change. But for us to implement a big change in our daily life, most of us have to agree on it in our practice, in our group, so that we don't do anything wildly different than our colleagues. Because part of medicine is also consensus among your colleagues. And if you really want to change things, then do journal clubbing and try to inform your colleagues about the evidence that there are, either at your local level or a national level. Okay, so that's all I want to say about my formula for going through this. And now we'll go through the journal club. Okay, so the background for this particular topic is as follows. When we or the anesthesiologist wants to intubate a patient, and here in Scandinavia it will be the anesthesiologist 99.9% of the time, then when they want to intubate a patient, then we need to pre-oxygenate, right? We need to pre-oxygenate the patient so that the interval, the apneic interval, as it was called, like between induction and when you put the tube in, that is the interval where there's a huge, there's a risk of them becoming hypoxic. And if you have a patient who is in a bad way, who has hypoxemia to begin with, like the indication for intubation is because they're hypoxemic, then there's a high risk that they will develop complications from that hypoxemia. There's this Scott Weingart used to call these hop killers, like the hypotension, hypoxemia, or oxygenation and pH patients, like the ones that are low in pH, because then they will have a high respiratory drive, they will have a problem. The deoxygenated patients, they will also have a problem, and then the hypotensive patients, because of your induction agent, amongst other, will also be a problem when you intubate patients. In addition to these, then the asthmatic patient and the patient with right heart failure, these 5 groups are highly problematic, and you can check out the videos from first 10 EM called RSI and then they die, or from Sarah Krager on this area for details. I've also made a video on this for details, but in essence, if we focus on the patient, when we want to intubate the patient, we need to get oxygen on board, and we also optimally need to denitrate, like I can never say this word, but denitrogenize their lungs through a tight seal, so that we buy ourselves some time before they become hypoxic in the space between induction and that you get the tube in. And why is this important? Why is it important that they don't become hypoxic? Well, this is the oxyhemoglobin dissociation curve, and this is from the quite famous paper on this area by Scott Weingart and I think Rich Levitan, and they they found out, or not that found out, they just encouraged us to think about this, that there is a really steep edge around 85, 90 in saturation. And beyond that, then the curve becomes inflected and much more steep, and it's much harder to get up from that than getting up from here. So there's a huge benefit to not getting below 90, 85, 90 in saturation during that period. And if we are below that, then we are going into really dangerous territory. So it makes sense that we need to preoxygenate. There's no doubt about that. What this study proposes is that if we do it with a positive pressure ventilation, then we may be able to, for different reasons, keep the patient higher in this spectrum than otherwise. And then there's a video from AIME, the AME Society, George Kovach's society in Canada, where they demonstrate this, and you can check out the video link here. Let's see if that's the video link. You can check that out, and then you can see for yourself with the positive pressure how the lungs is not collapsing. So there's merit to this point, that it's really important to preoxygenate with something with a PEEP valve or a positive pressure. But this study proposes that there is something more than just doing it with the PEEP valve. There might be some additional benefits as well as doing with the NIV or BiPAP or NIV. And this is something that, just by the look of it, there's a high pretest probability that this might work. So, and then I guess the risk is there's also the people are afraid that patients may aspirate because of the positive pressure. So that's one of the counter arguments here. Okay, so that's the pretest probability of the background. I haven't looked too much into the evidence here because I'm no expert in airway management, but you can check out the links that I stated before and that I will state in the end of this lecture to be able to make up your own mind about the evidence and your own pretest assessment of this. But as far as I'm concerned, this is the big study in this area. There's not too much, and the few studies that there are were not uniformly decisive. They didn't show uniform benefit for PPV. So this study, there's still equipoise going into this study, and that's why it was needed. And this study is done by a really, really big group specializing in the airway management, and they are very thought to be really good at this area. Okay, so I usually, once we go into the study, before we go into the analytic part of the study, I always encourage people to think about these three questions. Vinay Prasad and first Tiniam, Justin Morgenstern, and others usually encourage something like this as well, because it's not about the numbers. It's about you, before going into the trial, thinking about these three questions or something in the ballpark of these three questions. The first question is, what is the question that the study tries to answer? And what is it we actually need to answer? So this study tries to answer the question that among critically ill adults undergoing tracheal intubation, will preoxygenation with NIV reduce the incidence of hypoxemia between induction to 2 minutes after intubation? They only measure after 2 minutes after intubation compared to face mask oxygenation. And we'll go into what kind of face mask oxygenation this is. So that's the study question. Is that the question we want answered? It is somewhat, and we'll go into why. What we actually, this is a just to pick out one thing, the hypoxemia mentioned here. This is a monitor-oriented outcome, right? We actually want to know whether the patients die or get severe complications like brain injury or hypoxemic brain injury from these inductions. But other than that, this is probably the question that we want to want answered in this study. Then the study number 2. What do I do in my clinical work for this particular question? And again, this is not my specific clinical work, but what do my colleagues do? And does it look kind of the same? And this is where we, in my opinion, there is some variation in how RSI is approached by different anesthesiologists that I've worked with, and there is also high variability depending on the patient in front of you, and it's important to adapt your technique to to the patient in front of you. But I will say that some anesthesiologists in Scandinavia may not be as comfortable with RSI as they are with their operation or their usual intubation, and some anesthesiologists may not be that experienced in RSI as opposed to other areas of their specialty, and therefore we as emergency physicians have a great we can be of a great service or great help to our colleagues if they let us help them with, because they come into our area of our area of the department, right? And we need their help. That's why they're there. But and they have the skills that we and the experience with this that we don't have. But we may know some things from the studies that we do read from, and we could collaborate here to encourage our colleagues to do some of the things that we may know to be right according to the evidence that we read, or we might at least have a discussion about it. All right. So what do I do in my clinical work? Well, I've never intubated in the emergency department before, but and I know what I've done during my rotations for when I've intubated in the OR. But what we probably should be doing for a gold standard for RSI is we should be giving patients flush rate oxygen, meaning flush rate. There was a study that came out from the same group as the PREOXI trial here that said that we should be giving flush rate, which is high rates, as high as it goes. Like if you have your reservoir mask on, then the bag is filled with oxygen, right? It has to be, and then you will crank the oxygen meter up to more than 15 liters. You'll crank it up as high as it goes, as high as it goes, until the dial cannot be turned anymore. Then you will be at maybe 30 to 60 liters, as I've heard, and that we should do to pre-oxygenate. That's called flush rate oxygenation. I haven't seen that being done too much in the Scandinavian countries. Then we also need to do, and we can do this with a reservoir mask, or we can do this with a back valve mask. If we do with a back valve mask, MCRIT, Scott Weingart would encourage us to do PEEP, so have a PEEP valve of 5 when we're doing this, meaning that they do get some positive pressure ventilation. You will have to have the bed up so that the stomach is not pressing on the lungs while we're doing this. And then also encouraged by Scott Weingart and Richard Levitan and pioneered by them, I think, we will do what you call passive oxygenation with a nasal prong on their nose, as long as it doesn't hinder the tight fit of the mask, especially when you're doing BVM. It's really important that they have a tight fit, and you can even tighten that fit up with straps and so on. And I don't see many doing that. I don't think it's standard protocol either, but you could do that to improve the denitroglycation. And the passive oxygenation, as long as it doesn't if you have nasal prongs on, it doesn't give a problem. It doesn't make a problem for the tight fit of the mask. Then you can do that for passive oxygenation, and then during your once you've induced the patient, and they become hypoxic over here. If you look at the figure, then this is what you call in the Vortex model the safety margin or margin of safety, which we can increase, right, with optimal preoxygenation. But it was used to be like this, that we're not allowed to do bagging during RSI, and I was discouraged for that during my stay at my rotation in anesthesiology as well, when I was there a year ago. And so this is still a thing that they discourage us for doing gentle bagging, and it's probably it's a risk benefit kind of decision to take. And in the OR, when it's a stable patient, but it's an RSI because they for some reason maybe have ileus or like small bowel obstruction and so on, then it may be the right choice. But in the literature for emergency medicine, as I'm informed, this is safe if you do gentle bagging during the apnea time. And I think Scott Weingart, then if you can do gentle bagging, then the passive oxygenation is not as important. But if you don't do gentle bagging, then at least you should have nasal prongs on during the entire time until you intubate, right? And even during intubation, of course. And these nasal prongs can be replaced by a high flow nasal oxygen as well, and that would probably be even better. And I do seem to recall that there are maybe some Scandinavian studies on that, or at least some practices that do that in Karolinska. So that's what you do. You do that's the gold standard. This. So you decide, and while you're setting up your thing, you do pre-oxygenation and you do flush rate oxygen on the BVM or reservoir mask. You get the patient's head up so that they are in a 90, they are maybe in a 30 or 40 degrees angle of the bed, so that they have their abdomen away from the thorax. And then you do nasal prongs on for passive apneic oxygenation. And you do that even before the induction. And then you can just, when the induction happens, then you can just remove the BVM or reservoir mask, right? Sorry, you can keep having the reservoir mask on, or you can bag the patient during the induction, right? Until you need to go in with your scope, with your laryngoscope, yeah. So that's the golden standard. Okay, so that was the golden standard, and we have to think about, does the control arm look somewhat like that, my usual practice? Because if it doesn't in a study, then it's kind of a wrong way to do the study, or it might not apply to your way of doing it, right? So the study might not apply to your circumstances. Okay, and what would be ideal with this in mind? What would the ideal study then look like? And again, here I'm no expert, but I would say that you would have to have you want a randomized trial. Optimally, you want a blind trial if that's possible. Optimally, you want some kind of real world circumstances, which is called a pragmatic trial. I'm not an expert on whether a pragmatic trial or a strict RCT would be the best choice here. I guess it's a discussion that we might be able to go into. But what you want is one group gets the gold standard, the other one gets the gold standard plus or everything else is the same, besides the one thing that you want to intervene on, and here would be the pre-oxygenation with a NIV instead, right? So, all right, so going into the study, then we go do the PICOs to get an overview of what the study is. So these were the patients were critically ill adults above the 70 years old. Sorry for mixing Scandinavian and English here. Undergoing tracheal intubation. That means we have decided that these patients needs tracheal intubation. They excluded pregnant women, prisoners, those already receiving positive pressure ventilation, which is a bit controversial, and those with conditions precluding NIV, vomiting, severe agitation, and facial fractures, and so on. And the severe agitation we can talk about, they could have done DSI on those and so on. So the exclusions are there may be too many exclusions for what would have been the ideal trial here. Okay. Intervention, that would be pre-oxygenation with a non-invasive ventilation device using a tight-fit mask connected to either a conventional or a dedicated non-invasive ventilator for 3 to 5 minutes before induction. And the NIV used a tight-fitting mask connected to either a conventional, as we described, before induction anesthesia, and setting would be FiO2 of 100%, EPAP of 5, and IPAP of at least 10. This is kind of like, this is standard beginning starting settings for an IV in our department. So this is definitely what we do in NIV to begin with, and then you can always tweak it, but and then a respiratory rate of 10 as a bag off. So if they and this is where we might differ, because if they hypoventilate, then this will breathe air into them at a rate of 10 per minute, and we would meaning that the NIV works as a ventilator, like a ventilator device, and this is something that is then that could be used during the apneic period when they don't breathe. And we usually don't do that in any circumstance, almost any circumstances in our hospital, because we don't want to use the NIV as a ventilator, especially if someone is obtunded. All right. Then control group, pre-oxygenation using an oxygen mask. A non-rebreather or a back valve mask. They could decide themselves because this is a pragmatic trial. Then the O2 mask has supplemental oxygen using either a back valve mask or a non-rebreather device without manual ventilation before induction of anesthesia. So they were not allowed to be bagging them. And that means also like the crash intubations, they were excluded here. The worst patients, the worst of the worst were excluded here. And then the flow rate has to be at 15 or above. And this is, we'll come into the arguments, but this is one of the main arguments that we don't know. We don't know whether like they could have done this better, to say like this had to be they could have noticed how much oxygen, because that would be important because of the evidence and the gold standard. So this might be said that this is not totally gold standard, perhaps, as a minor point. Okay. And the outcome, the primary outcome, which is the only one that we really care about, is hypoxemia during intubation, which was defined as a SAT below 85 between induction and 2 minutes post-tracheal intubation. And the secondary, there were several, and I won't list them here. But there were also some safety outcomes, which is great to have those in these trials. And the safety outcomes were primarily aspiration and also cardiac arrest. Right. So, and what kind of study was this? It was a multi-center, unblinded, randomized pragmatic trial, meaning that the multi-center, more than one center, unblinded, meaning that they knew whether they got an NIV or they got a oxygen. And I guess you couldn't really blind, or you could put a NIV on both patients and then just go with FiO2 on one and not giving them positive pressure and ventilation on the other. You could have done that, but you will know, the patient at least will know whether you get positive pressure and ventilation, and usually the people in the room will usually know by maybe blood pressure decreasing and so on, that there might be positive pressure involved. So it's not totally possible to, I think it's hard at least to blind this, and that's probably why it wasn't blinded. Also because it was a pragmatic trial, meaning, as I understand pragmatic trials, is that they don't have to follow the strict protocol. So if the patient is randomized, but they think, oh, this patient is randomized to the NIV, but they think, oh, it wasn't, we cannot make it anyway, then they could switch to the other way of doing it as well. If they could just switch to back valve mask if they thought that was the best thing for the patient. So that's part of the pragmatic trial design, as I understand it. So there's more free room to choose what kind of, like, quote unquote golden standard that you're using as well. So that's why 15 liters or above was encouraged. So it didn't really you could be using 15 liters if you wanted to, but yeah. So that's the pragmatism of the trial. But the thing is with the pragmatic trials is that the good thing is that they are applicable to many. It's more, as I understand it, more generalizable because it's more real. It's not an experiment in the same way as a normal RCC is. This is more a real everyday decision kind of thing, and that's why it might be more applicable by doing it pragmatically. And also important, there was 7 EDs, and all of them are in the US, and then 17 ICUs, and I think it was like 25% were in the EDs intubations, and 17% were in the ICUs. Okay, so that's the PCOS. Okay, so this is a graphic illustration of the intubation and induction and pre-oxygenation and how they did it in the trial. So if we look at the y-axis here, the x-axis, then you have the initiation of pre-oxygenation here 3 to 5 minutes before you do the induction, and then when you induce the patient, you wait until the paralytics and the inductionation works, and then you initiate. And Ruben Strayer would say you should initiate it almost immediately, but usually you would initiate a bit later here, your laryngoscopy. And once you initiate your laryngoscopy, that's when you are in an apneic period here where you need to get your tube in, and you need to do it as fast as you can. This is where they can become hypoxic. Potentially, you can also become hypoxic here because you're not breathing at this time, right? So, and you can see here the respiratory effort is going down, right? So this is where you might be doing gentle backing, and this is where your passive oxygenation might work, and also here, but gentle backing here and then passive oxygenation here. Okay, so in the NIV group, the NIV group, then they did non-invasive ventilated ventilation. That was mandated because that's the only thing that was mandated when and then during the space between the induction and your direct laryngoscopy, you could either do gentle backing or you could just continue with non-invasive ventilation. It was up to the doctor doing it, and then you do your intubation attempt. And by the way, this group was really experienced. It was like they had to have 50 intubations prior, which is quite a lot. So they were somewhat experienced residents, mainly. Okay, and then in the control group, they did non-rebreather or back valve mask, and they could have had a PEEP valve or not. That was not registered, whether they had it or not. So we don't know. Then here recommended providing oxygen with non-rebreather mask without ventilation, a back mask without ventilation, so that they were not allowed to do. They were allowed to do gentle backing as well, so they could do whichever here. And in either group, they could all the time have either high nasal flow oxygen, like NHF, or they could have just standard nasal cannulas, right? This is what we call passive. So this is pretty much golden standard, but there's wiggle room to which kind of, and they don't explicitly tell us whether it was super high flow, like as high as the dial goes, or it was just 15 liters. Okay, and then the results. So first of all, the first part of results is whether or not the groups look alike. And sorry, I have to go a bit closer here because it's a bit small. But in general, the groups seem to look very much alike. And that means that the randomization has happened in a good way, right? The randomization was successful. And the other thing you can always take away here from is, do they look like my patients? Well, these patients were 6 years old. They around 25% of them were in the emergency department. They were quite sick. 20% of them had cirrhosis and so on, right? So 60% of them were altered. Several of them have pneumonia, as in our case here. So these look very much like many of the patients that we would intubate. in the ED in Scandinavia. Then we have this flow diagram. This is also part of the results. So we have they enrolled 4,000, almost 4,200 patients, and then they, through their exclusion criteria, had to exclude quite a lot, right? 3,000, so that they're back to 1,100. Sorry, 1,300, and then these were randomized. And the number here is important for the power calculation, right? So they do a power calculation beforehand to know whether or not, well, like the primary for the primary outcome, not for the secondary outcomes, but for the primary outcomes, they do a power calculation, and it tells them the power calculation is based on certain assumptions on how good your intervention, how good you think your intervention will be. And if you think your interventions will be, if you're looking for a high, you have a really good intervention and you think it will be a massive success, then you don't need too many people. But if you're looking for a small benefit, then you will need a lot of people. So I don't know where this falls on this, but they did achieve their power calculation, what they wanted. So that's good, meaning that we can actually use the study. Underpowered studies are really hard to interpret, and sadly there's lots of those. All right. And you could go into details about the exclusions, and we might, but this is a quick video, so I won't go too much into it. And then the primary results. This is a primary result here. Hypoxemia during intubation, meaning below 85% in that, after their induction, and up to 2 minutes after intubation, and 57 of 624 in the non-invasive group, and 118 of 637 in that group. And this was statistically significant, that there was a clear benefit for the non-invasive if we take the results at hand, or at clear value. All right. Okay, they show in the supplemental material, they have this graph as well, where you have the y-axis, which is people who has the amount of patients having hypoxemia, and the x-axis is the where in the intubation in the intubation stages they are. So just quickly, the blue one is the oxygen mask, and the red one is a non-invasive mask. And what you do see here is, like, how do you interpret this? Well, these stick figures going up here is confidence intervals, right? So if the confidence intervals of the red goes over the one in the blue, then it's not significant, even though it seems like it may be. You could say there's a tendency here that the NIV mask helps, because there's a less amount of hypoxemia in these as opposed to the blue one. But it's definitely separated here, and here is between induction and 2 minutes after intubation. So you might get a better pre-oxygenation. That's debatable. From this data, there might be a trend, as they say, but here it's definitely separated. And they also did some kind of subgroup analysis where they had some, I don't know if they were a priori subgroups or they were post priori or after the fact, but what they did do was they separated out the ones that were intubated in the ED, for instance, and in the intensive care. And actually in the ED and the intensive care, the effects were not that significant, or they were not. They crossed the 0 point, right? There's a tendency, but they weren't big enough numbers to be totally sure. But in the intensive care unit, then they were significant, statistically significant, right? Then acute hypoxemic failure, if you do have acute hypoxemic failure, then there was a bigger advantage of doing the NIV than if you didn't. But there was and I cannot tease out whether this hits the line or not, but it seems almost statistically significant, if not statistically significant, that even the patients who do not have hypoxemic respiratory failure may benefit from this, if you look at this study. Then you see this big thing where you have the patients with high BMI having a more benefit than the ones that don't, and that makes sense because they usually have more atelectasis. And depending on the Apache score, I think it's how critically ill they are. It's a critically ill kind of ICU score, and it seems like the ones that are the most critically ill, the less critically ill, may have a bit more benefit. I'm not sure how to interpret that. And then how high the FiO2 were in before. So the ones that did get oxygen before intubation, an hour before, like they were hypoxemic even an hour before, they may benefit more, but it seems like everyone kind of benefits, right? There are some outlier here, but in general, all across the board, it seems almost like they are all benefiting, and you could extrapolate the ones in the ED that they may also go into this line, but yeah, when you look at the entire thing. And just as a last way of showing the results is the lower saturation, oxygen saturation was like some of the NIV patients did get down to 70 as well. Some of so that's one point from taking from this. So it's not perfect, but there was definitely a separation between the amount of patient that had severe hypoxemia in all and hypoxemia in all across the board in the oxygen mask versus the non-invasive. All right, and then we look at the rest of this table. That's I always they should always do the primary outcome in big letters, I think, because that's the most important, the only one we actually care about. The other ones are just less important and hypothesis creating, right? But the secondary outcome, and they have to their great they have called this exploratory procedural outcomes. So meaning that they have hypothesis generating. So they are trying to emphasize that these are not as important. What I want to delve into is the exploratory safety outcomes. Aspiration wasn't any higher. It crosses 0 here, so it wasn't significantly higher in either group, and it might be a trend actually for the NIV group to be less, right? So and then all the others is also like, so there's all the safety outcomes were good. There's one more I wanted to show is the cardiac arrest. Also, it wasn't quite significant, but almost. It seems like one of the hard outcomes that we wanted, cardiac arrest, is almost significant here. So there might be a really hard outcome here, a really strong trend that patients on NIV would not go into cardiac arrest. Good. Okay, so that was the results. That's kind of that's the results. And then what we want to do is how much do we believe in the results? So that's for analyzing that, what we call the internal validity of the study. How much do we think this is true? And what weight can we put on this result? How much do we believe in it? And for doing that, we have to do a limit. We have to look at the limitations of the study, and a systematic way of doing that is doing a checklist. And I've pulled this checklist for RCTs from the SGEM, and we can just go through it. So for question 1 was the population included or focused on the ones included, were they focused on those in the ED? And yes, they were. Just 25% of them though, so 75% of them were not, and an important detail here is that, well, in the patients in the subgroup of the ED, it was only a trend for positivity, for clinical significance, or sorry, statistical significance, but it's a really strong trend though. Were the patients adequately randomized? In table 1, it seems like it, and were also concealed. Yes, we think so. We have no reason why not. The patients were analyzed in the group in which they were randomized. There wasn't any crossover. No. The study patients were recruited consecutively, meaning that there was no selection bias. No, we don't know whether they were consecutively, like every patient coming in the door during day and night, or it was only during the day, or they don't mention. The patient, sorry for all my spelling errors here. The patients in both groups were similar to with respect to prognostic factors. Yes, we saw in table 1 they were kind of similar. There wasn't much between them. All participants were unaware of group location. No, it was an unblinded trial. All groups were treated equally except for the intervention. No, they weren't, because it was a pragmatic trial. There were nuances that they could be treated a little bit differently, and that's part of the critique that we'll go into. Follow-up was complete. Yes, it was, and all patient important outcomes were considered. Yes, cardiac arrest we saw, but that was not a primary outcome. They didn't believe maybe that would be good enough, but it's easier to show that a surrogate outcome is positive, right? So that's why it probably was a secondary outcome, but the primary outcome of hypoxemia also was good. Yeah. What we could have had was also like long-term follow-up might be missing. We could say that. So but it's probably, you would need much bigger numbers for long-term follow-up to see whether the hypoxemia actually did anything to the patient, right? That's a much bigger study to do. The treatment effect was large enough and precise enough to be clinically significant, yes. And financial conflicts of interest, well, there was none disclosed. The study was primarily financed by a grant from the U.S. Department of Defense. Don't know why, but at least it's the governmental organ that is encouraging people to do this, right? And to finance this. What I will mention though is a lot of these big blocks that I mentioned, Rebel EM, First 10 EM, MCRIT, they seem to have all gotten, or some of them at least have gotten, a print of this before everyone else, so that they could analyze it, and then when the embargo was lifted on it, then they could post their conclusions about it. So that's always a bias, right? Why you don't? This is a publication bias, because they don't get sent that many studies. But this particular group decided to do that, and then that's a bias, right? Why this study, which is a positive study, came through, but others didn't, right? So and also the study is about a lot of the things that these blocks have talked about for a long time, so there's a confirmation bias risk here as well. Okay, going on to strengths and weaknesses. And so the strengths are obvious. This is a really well done RCT. It was pragmatic, which is both a strength and also a weakness sometimes, but we'll go into why it's a strength, because it is much more applicable to every day, because it's not too experimental. And it's a well done study, right? And so lots of strengths here, is well done and well executed. Some of the weaknesses are not all the patients were in the ED. That's a weakness from our standpoint for external validation, whether we can use this or not. They excluded some patients, especially the sicker ones, the ones that are agitated and so on. So the sickest ones, which really needs pre-oxygenation, we still don't know what to do with those. Whether we should try to prioritize to get their SATs up a bit before we try to intubate them. But these are really like when Scott Weingart talks with the authors and Rebel EM, Celine Rosset also did it. It seems like lots of the the patients, like this group is really high, have a high experience in airway management, and their hospitals have as well. So it's a high expertise group that has done this. And the ones that are crash intubations, you and I would probably not either, like we probably couldn't pre-oxygenate those patients either. So it's probably a lot of the exclusions are quite good, but the agitated patients, you could have given them ketamine, like a DSI or something like that. So, and the ones that are already on PPV, those we probably would just continue doing PPV on and then intubating them. And the risk with these exclusions is that it pulls the study results towards NIV being better than it probably is, because we would probably use it in also like these really, really sick patients and also the pregnant patients, and it might not work as well in those. So if those were included, then the study result might not have been as good as numbers need to treat up 10, which was here. Is there a selection bias? And it might be for the reasons that I've mentioned before. There were many exclusions, and this is a pragmatic trial, meaning that they could kind of do what they wanted once the randomization has been done. And one of the main things that a lot of the blogs talks about is whether or not it was giving high, like this superflow oxygen, like flush rate oxygen. Was that given or was it not? And was there a PEEP valve or not in the control group? Because if there wasn't FiO2, if it was only, if the control group was only 15 liters, then you could argue that, this is not the positive pressure ventilation that's the reason for the benefit. It's just that the FiO2 was higher in the NIV group. And you could also, but if it was okay, the same argument could be made about, well, if the back valve mask didn't have a PEEP valve, then it was mainly the PEEP. So it doesn't matter too much, because that's the thing about the pragmatic trial, that this is a care bundle. Like the NIV is both high FiO2 and it's positive pressure ventilation, right? So it doesn't matter if you have the machine, but if you don't have the machine, that's when you want to like kind of tease out which one was the most important part of this bundle, of this package of the NIV, and well, that we cannot find out, but the authors think that it's not FiO2 because their groups were instructed to give flush rate oxygen beforehand, and they usually do that as a golden standard in their groups, but you never know. It was not registered, but both Weingart and the authors think that it's mainly the positive pressure ventilation thing. And Weingart, for reasons that I'm not quite sure of, believes that PEEP valves are not the same as NIV, and I'm sure there's good reasons to think that. I'm just not good enough to know that. But the PEEP valve. So if you don't have the NIV, then at least you should use a PEEP valve, and you should use a tight fitting mask as well. That's what Weingart would encourage. And then you can always argue that, it's a MOO. This is a monitor outcome. It's not a POO, but there's a strong association with a POO, right? And we even saw a strong tendency for cardiac arrest, which is a POO, in the results section. So I put this in the middle. All right, so the post-test probability after doing this test, which is a study, what do we think? So MCRIT and their authors, I believe, I'm paraphrasing here, but I believe that they think use NIV and positive pressure ventilation in everyone. Because we don't know who's the sick ones or who are going to be the hypoxemic patient. So every RSI should be performed with a NIV kind of positive pressure ventilation, not just back valve masking and PEEP. And then they kind of argue about whether it was FiO2, which was the reason, or the PPV, but they think it's the PPV, the positive pressure ventilation, that was the reason why. And then first NEM use he would say like use only NIV for the shunt patients, for the ones that are not getting better, because he believes that the ones that are getting, like the ones that are really are good enough oxygen, like who are getting enough oxygen on just back valve mask or on high flow oxygen without the NIV. If they get up to 100%, then he believes it's good. But the problem is, would Weingart and the authors argue that in this study, as we saw, there might be a subgroup that, like we could see in the subgroup, that even the ones that are not hypoxic and even the ones that are not that sick might actually benefit from this. But it might be a much smaller group, and there's a cost-benefit analysis here that we don't know whether we have, like, if everyone needs an NIV every time they're intubated. At least you should make the NIV mask follow the patient during their entire flight in the hospital, right? I don't know, but at least as I understand it, then for the ones with shunt physiology and the ones that are BMI over 30, those are the ones that are highest recommendation for doing NIV. The Rebel EM says as kind of like the same thing as first EM, though emphasis on the PEEP in all. Even though also in the one, like if you don't have the NIV, then you could use the PEEP. And the SGM says, and this is word by word, the PREOXI trial supports the use of non-invasive instillation for preoxygenation during emergency intubation in critically ill patients. By adopting NIV as a preferred preoxygenation method, physicians can reduce the incidence of hypoxemia during the high-risk procedure. Yes. And I think, I'm no better than these guys, right? But I believe that NIV preoxygenation may be superior in all patients and probably works much better in select groups like shunt and high BMI over 30, and reduces the risk of post-induction hypoxemia, which may translate, I didn't write that down, but which may translate to lower risk of cardiac arrest. There's a high likelihood that it might. And then if you cannot do, but you should also do all the golden standard things like PVAL and gentle backing, or just keep the NIV on during that time when you're doing the induction. Okay, and the case resolution. Because of suspected shunt physiology, you encourage anesthesia to preoxygenate the patient with NIV, 5 EPAP, 10 IPAP, and a FiO2 of 100. And then maybe give passive oxygenation with nasal prongs, and then keep doing it during the induction phase until they are ready to put the laryngoscope down the throat of the patient. And we hope they have also read this. All right, that's the PREOXI trial in an hour. Thank you so much for listening, and I hope to see you again next time. Thank you. Bye-bye.